and move on to Professor Ted Cohen. So Ted is Professor of Epidemiology at Yale. We've got the details up now. Ted, over to you. Thank you.
Great. I want to thank the organizers for inviting me to join this workshop. And it's a pleasure to follow Slim, who I think really introduced some themes that I'm hoping to build off. Slim really focused on lessons learned from other viral diseases, in particular Ebola and HIV. I was asked to speak about what we could learn from tuberculosis. And to be honest, my first reaction was to think about all of the ways in which these diseases differ in important ways. I'm having some issues advancing. Oh, there we go. Okay. So these are diseases which on first blush have very little in common besides the fact that they're spread through the respiratory route. They're caused by pathogens in completely of completely different types. TB is a bacterium, COVID-19 is a virus. They have case fatalities that differ by orders of magnitude. The temporal dynamics of these diseases are quite distinct, with TB occurring in individuals over months to years, while as in COVID, this is an acute viral infection with a natural history of days to weeks. These lead to distinct epidemic dynamics where we see TB epidemics occurring over years, decades, and even centuries, while COVID-19 epidemics move rapidly in weeks to months. Also importantly at this point, we have a very different interventional toolbox, and Slim talked about sort of the importance of thinking about what tools we have available to us to combat these diseases. For TB, we have a partially effective vaccine, others in development. We have highly efficacious antibiotics. For COVID-19, our toolbox is relatively bare at this point. The second concern I had about trying to understand what could be learned from TB was just thinking about whether, as a TB control community, we're really in the position to tell people what works. I'm presenting data from the WHO Global TB report from 2019. This green curve represents, over the past 2 decades, very slight decreases in estimated incidence of TB at a global level. This is a disease which we're making progress on, but it's been slow. We're seeing decreases of only about 1 to 2% at the global level each year. TB is characterized by a large fraction of estimated incidence that is currently going untreated. So approximately 30% of incident cases we estimate are not being detected or treated. And this results in a large case fatality ratio of 15% for estimated incident TB cases, despite the fact that we have effective antibiotics. But in thinking about this further and trying to understand what are the productive ways we can think about our global experience with TB in addressing both COVID-19, but also more generally, future introductions of respiratory viruses that we are likely going to have to address. I wanted to focus on 2 characteristics between these diseases that have been striking and observed everywhere. The first is this question of transmission occurring prior to the onset of symptoms. So I'm going to call this subclinical transmission. This is a term we could talk about exactly what we mean by this, but what I'm going to try to argue is that it's incredibly important to consider how diseases where there is either asymptomatic transmission or an insidious onset of symptoms such that an individual's ability to recognize those symptoms and get diagnosed and potentially treated might be limited. I also want to talk about the striking association of these diseases with different metrics of social vulnerability, material deprivation, poverty in particular, which has been noted by many researchers for both these diseases. First, let's briefly look at some of the evidence for asymptomatic transmission or subclinical transmission of COVID-19. These are data from China, from He et al. In evaluating sort of careful epidemiologic evaluation of transmitter-transmittee pairs of COVID-19 cases. Best estimate was that in this particular setting, approximately 44% of transmission events happened before the onset of symptoms for the infector. And similar estimates have been generated in other settings. So although this was not well recognized early on in the epidemic, it's now abundantly clear that subclinical transmission is important for this disease. This is also the case for tuberculosis. A large systematic review conducted on data before drugs were available to treat TB suggests that individuals with active disease have approximately 3 years of infectiousness prior to their case resolution, whether that's self-cure or death. So incredibly long periods of time. This is a chronic respiratory infectious disease where these individuals can be out in the community for long periods of time and infecting others. More recent data are consistent with the idea that despite the availability of antibiotics, there's substantial subclinical transmission of tuberculosis. On the right, I'm showing data from a review of TB prevalence surveys. These are data from Asia, but we see similar results in other areas where large fractions of individuals diagnosed with prevalent tuberculosis do not report any symptoms. So we see here among individuals with bacteriologically proven TB, up to 80% of individuals found with TB do not report any symptoms. So it's well appreciated by the modeling community and others why subclinical transmission would present particular challenges for control of respiratory diseases. Christoph Fraser and colleagues sort of elegantly provided a framework for why consideration of both the reproductive number of a pathogen as well as the fraction of the infectious period during which individuals lack symptoms need to be considered when thinking about the controllability of a pathogen. This type of work has been expanded. This is work by Corey Peak and colleagues, showing how even for diseases with relatively high reproduction numbers, as long as the onset of symptoms happens prior to the onset of infectiousness, these diseases can likely be controlled just by providing individuals with access to health systems and that they can seek out on their own when their symptoms develop. However, even for diseases with moderate or relatively low reproduction numbers, when the onset of infectiousness precedes symptoms, even by just a couple of days, we need much more stringent interventions to assure control. Things like quarantine of individuals exposed and potentially even more stringent interventions such as we've seen in COVID, like lockdowns, which are difficult to maintain and have lots of collateral impacts on communities. Let's turn now to the second point of commonality between COVID-19 and TB. There's a long history of research and other data which suggests very strong associations between tuberculosis and social vulnerability. In this top panel, I'm showing data from Liverpool between 1985 and 1990, showing the relationship between TB notification rate and several measures of material deprivation. So there's strong positive association with more deprivation and higher notification rates of TB. Similarly for COVID-19, looking at individuals with higher measures of social deprivation, we see in this Oxford-based study that we see increasing rates of SARS-CoV positivity in these groups with more material deprivation. So this is not surprising to us. We've all been following the media stories demonstrating this relationship. I seem to be having an issue getting to my next slide. Vincenzo, can you help me? Vincenzo, if it's easier, I could present locally. I'm not sure what you'd like me to do.
Yes, please. I think that's the safest option.
Okay, let me just call up my okay. Can you see my screen?
We can, thank you.
Okay. I will just try to present from this window. Can you see my cursor?
Yes.
Okay, fantastic.
All good.
All right. I think it's worth taking a moment to step back and think about the mechanisms by which these types of measures of social deprivation actually operate to increase the risk that individuals experience. So first, when there's this type of heterogeneity in communities, we'd expect that individuals would differ in their ability to limit exposure to respiratory pathogens. So in particular, social vulnerability or poverty may be associated with denser living conditions, the need to participate in higher risk occupations from the perspective of exposure, and perhaps more limited ability to engage in prevention. And what I mean by this is things like being able to, for example, work from home might be less common with individuals who participate in jobs that don't allow for that type of flexibility. We'd also expect that in the presence of this heterogeneity, individuals would differ in the severity of infection, whereas individuals with social vulnerability would be likely to experience greater medical comorbidities, have higher risks of malnutrition, or other factors which might increase the risk of poor outcome given infection. And finally, much in the same way that individuals with social deprivation might have difficulties in mitigating their risk of exposure, we should also consider how these factors might operate to prevent individuals, if infectious, from limiting their risk of onward transmission to others. And this all can be compounded when there's some associative mixing, which we would certainly expect with many of these factors, where individuals with social vulnerability are more likely to have contact with other individuals with social vulnerability than others in the community. And the modeling community has also thought deeply about how these types of heterogeneities extend to present particular challenges and maybe even opportunities for epidemic control. So in this top table, I'm presenting a small panel from Mark Woolhouse's paper, where he's evaluating how both vector-borne diseases as well as some sexually transmitted diseases have much larger population level reproduction numbers because of the existence of this type of risk heterogeneity, where some individuals experience outside risk, and that puts the entire community at greater risk than would be expected otherwise. This thinking has been expanded to think about TB as well. I'm presenting just one example of that here. This is a recent paper by Gabriela Gomez and colleagues, looking at how the spatial risk of tuberculosis can differ quite markedly within a single country. We can see 1 to 2 order of magnitude differences in TB burden when we evaluate notification rates at different administrative levels, and how the existence of this type of heterogeneity and these risk differentials may both drive epidemics, but also offer perhaps unique opportunities for efficient targeting of interventions to areas most at risk. A particular example of this type of risk heterogeneity that I think is worth discussing in its own right are prisons. I'm presenting a table on the left from an unpublished study by Olivia McCord's, Leo Martinez, and other individuals in Jason Andrews' team, who have been doing an extensive review of the rates of incident TB disease in prisons. This particular table reveals that the incidence rate of TB among prisoners is over 10-fold higher than the incidence rate of TB in the communities in the community surrounding these prisons. But when we look by region, this differs quite substantially between areas, with South America standing out as a particular example where the rates of TB in prisons exceed by 30-fold those in the community. We've seen similar dynamics with COVID-19. These are data from the US showing how the incidence rate of COVID-19 has really taken off in prisons in a remarkable way. This is especially concerning in the US and in other places where the prison population has been growing for many years, and I think is of particular concern. And this should be of concern to us, not only because these types of heterogeneities put people who experience these forms of material or social vulnerability at increased risk, they also present increased risk for our communities as a whole. So these are further data from prisons. These are fascinating data out of Brazil, looking at the rates of tuberculosis incidence, first as a function of time in prison in Brazil. And so we see rates increase steadily over at least the first 5 years of imprisonment, from levels that are similar to what are in the community to levels that are much higher. This is on a log scale. So we're going from incidence levels under 50 per 100,000 to over 1,000 per 100,000 for individuals remaining in prison for 5 years. So shockingly high increased risk of exposure for prisoners. But I think nearly as important as recognizing the risk that these individuals experience within prison is what happens after they leave prison. And this graph shows a declining risk of that individuals experience in terms of incident TB disease, going from levels that are elevated because of their time in prison, but only gradually coming down to the levels experienced by the community at large. So this is all transmission opportunities that are happening in the community because these individuals had experienced this transient period of very high risk. Similarly, for COVID-19, these are data that I pulled from California yesterday. which I think are they were surprising to me. They track the number of active COVID cases in California prisons, over 1,200 so far. But this statistic is shocking to me. We've had almost, between 300 and 400 cases of known active COVID disease in prisoners, during which time these prisoners were released back into the community. And they're, sort of the implications of this type of sort of flow between prisons and the community, I think, is something really worth considering. The final consideration that I would like to talk a little bit about is the relationship between social vulnerability and subclinical transmission. So I've taken some time to describe the existence of subclinical transmission for both TB and COVID, the existence of strong associations between social vulnerability and risk of TB and risk of COVID-19. But I want to think a little bit more deeply about the potential relationships between these two issues. And in particular, trying to understand whether or not individuals experience either material deprivation or social vulnerability in other ways may have longer periods of what we're calling subclinical infectiousness here. And what I'm would like us to think about is whether or not sort of the existence of greater barriers to testing for those with social vulnerability, or the existence of greater disincentives for seeking diagnosis might be associated with this type of social vulnerability. And as sort of particularly striking example of this, I want to focus on sort of the location of diagnostic testing sites in relationship with both of these diseases. So this is a map of Chicago this is work that is being done by one of my doctoral students, Emanuela Asabor. This is, Chicago is one of the most racially segregated cities in the United States. These pink dots represent areas where there's a high concentration of Black Americans. These blue dots represent areas where Caucasians are predominant. And these yellow dots represent the COVID-19 diagnostic testing facilities as of June 13th. And you don't need any statistics to understand how individuals who are Black in Chicago may have increased barriers to seeking testing just based on the location of these particular testing facilities. This reminded me of work that has been done recently by Peter McPherson and Liz Corbett and colleagues in Malawi. This is data from Blantyre, and I'd like to first sort of orient you to these figures. It may be difficult to see, but these black triangles in this figure, located sort of predominantly in the center of the city, are the TB diagnostic facilities available for patients to be diagnosed in Blantyre. The color scale here is essentially a map of poverty, where we see individuals living more centrally tend to be individuals who are wealthier, and individuals living on the periphery are poorer. So there's a clear pattern where poor individuals have a longer distance to travel to get to a TB diagnostic facility. When we look at the TB notification rates by health area, we see that the notification rates closer to the clinics are higher than notification rates further away. This is shown here on this graph, both for all TB cases and bacteriologically proven TB cases. As we move further from the clinics, the notification rates decrease. Similarly, because of this relationship with poverty, as poverty increases, the notification rates also decrease. And so the naive interpretation would be that, in fact, sort of in opposition to all of the data that we've ever collected, that in this particular setting, poverty is inversely related to the local incidence of TB. However, this is not what we think is going on. And one piece of evidence to suggest that, in fact, that this represents bias, that the reason that we see these lower case notification rates further away from the clinics is because these individuals are experiencing more barriers to diagnosis and care, is when we look at the severity of disease by in relationship to the TB notification rate. As we move further away from the clinics and the notification rate goes down, the severity of disease, here we're sort of characterizing severity as the fraction of individuals that have more bacteria in their sputum gets larger. These are also individuals who are very likely more infectious than others. So this presents, I think, strong evidence that the underlying mechanism by which we're seeing lower case notification rates further away from these clinics is actually reduced access to care. Okay. I want to take a moment now to turn back and think about, how we can learn from these commonalities. So now we've established that, despite the fact that these are quite different diseases, there are several things that are held in common. And I think, perhaps I was being unfair about our community's ability to respond to the TB epidemic. I'm presenting sort of longer time series data from Chris Dye's textbook here, where we see that there's been sustained decreases in TB notifications in many countries that have occurred over decades. And so although now we've seen progress slow to 1 to 2% decreases a year, we have had historical periods where decreases have been much higher, approaching 10% per year, sometimes for a decade or longer. And so those are achievable gains. And the question is exactly how were those gains achieved? And certainly there's a lot of debate about this in the TB community. We know that TB specific interventions, including the availability of antibiotics, have been important components of the TB response. But I would also argue that there's strong reason to believe that there are non-specific responses that governments and communities have made that have also served our experience in combating TB well. This is data conducted by Andrew Soroka and a team from the WHO, looking at the relationship between spending on social protection as a percent of gross domestic product at the country level. We see that countries that spend very little on social protection tend to have higher TB prevalences. This relationship is strong, but of course this is an ecological analysis, and sort of attributing causality is something that we should do carefully. But I think that there are strong mechanistic reasons to believe that that increased spending on social protection should buy us some additional control. These are some estimates from this group suggesting that increasing spending on social protection can buy us decreased prevalence, incidence, and mortality for this particular infectious diseases. But these would be non-specific interventions that might have benefits, that would likely have benefits for other respiratory pathogens as well. And these types of lessons have really been built into the global response to tuberculosis. So the current strategy articulated in this NTB document, I think, is striking in its sort of implicit recognition that our ability to contain this disease better depends not only on developing new TB-specific drugs, new TB-specific vaccines, which we know are going to be necessary, but also the development of governance and policies which address the type of social vulnerabilities that we've been discussing are a feature of both TB and COVID. So this entire second pillar is about sort of building supportive systems and interventions that are not specific for TB. Things like universal health coverage and other sorts of mechanisms of poverty alleviation are going to be key elements of our TB response, but also I think would serve us well in considering control of other emerging respiratory diseases. So in summary, the key points that I take away from this consideration of what lessons can be learned for TB for other respiratory diseases are that social vulnerability does more than create health inequity. It creates communities that are more vulnerable to the establishment of pathogens and makes control of epidemics more challenging. And I think it's critical for us as a community to figure out how we can make the argument to policymakers that that addressing health inequity is not simply sort of an argument about some sort of beneficence or some moral charge to address these health inequities just because some individuals are experiencing more risk. I think we should be making those arguments, but sort of my read of the political situation, and this might reflect the fact that I'm in the U.S., is that we need to and we should make arguments about how our entire communities suffer increased risk because of the existence of these vast heterogeneity in risk, and these need to be addressed head on. I also believe that particularly for diseases where there's substantial subclinical transmission, that this feature of pathogen exacerbates these risk differentials, as the most vulnerable individuals will have additional barriers for obtaining early diagnosing and or reducing exposure or their likelihood of transmitting to others. And finally, I think sort of in consideration of what we've observed both with TB, but also for COVID and likely in the future, for countries with large incarcerated populations, the idea that prison reform needs to be a key part of our response to thinking about how communities can be set up to prevent epidemics from occurring is an imperative. And I think that is the end of what I had to say about TB and lessons for other respiratory diseases.
Thank you very much indeed, Ted. That was absolutely excellent. And thank you for coping with the technological challenge in the middle as well, which all went very smoothly. Time for maybe the odd question. As before, please put your questions in Slido or put your hand up if anyone would like to ask a question. There will be our opportunity later when we have a general discussion. Chris Dye, maybe one question from you that you've put up. Would you like to ask it, or shall I?
No, I'll ask it, Valerie, if I may. First of all, thanks, Ted. Fantastic. Really enjoyed that. But of course I wouldn't I? Because I spent years thinking about tuberculosis, as have you. Just one observation and one question, if I can. Your piece about TB in prisons in California was fascinating, and it actually takes me back to Russia in the 1990s and the early 2000s, where prisons were fundamentally a source of transmission and a source of infection in the community because of the remand system that was operated in Russian prisons. I don't know if it still operates, but at the time, prisoners who were held on remand in prisons were held for short periods of time and then released. So essentially there was a revolving door between the community and prisons, which were hotspots for tuberculosis and indeed multi-drug resistant tuberculosis. And the prisons therefore were feeding TB into the rest of the community. So that sounds like similar circumstances for COVID, although I don't know if it works in quite the same way. But my question is really about the problem of TB as a non-emergency as compared with COVID. You know, TB will kill more people this year than COVID will. We're approaching 1 million deaths perhaps from COVID, but it'll going to have to get to sort of 1.5 to 2 million to compete with tuberculosis. And TB does that every year and has been doing it for years and will probably do it for years into the future. But a difficulty for all those who've worked in TB is that it's never really been considered an emergency. It's just part of everyday life. So I'd like to have your thoughts on that. Why is COVID and diseases like COVID different? Why are they emergencies? And if it were the case, for example, that COVID eventually killed 1 million people a year, I don't think it will, but let's say it kills a few 100,000 people each year, and it does so regularly and endemically, like TB, will we just come to live with it? Over to you.
Yeah, I mean, I think this has been incredibly frustrating to watch as a TB epidemiologist, and I know that my colleagues share this, where we recognize that yes, this is new and this is scary when we're in the midst of experiencing a new pandemic. But as you said, you know, the human toll of COVID is likely to be exceeded by TB, not only this year but well into the future. Yeah, this strikes me as one of the most difficult things about how we generate the type of investment that we need in responding to TB, not only because things are fairly stable year to year, and but also because of the people that are most effective are those that have the least political agency. And I don't know what the answer to that question is. I think it is critical that we figure out how to increase the urgency of response, recognizing that even with sort of large investments in TB, it's going to take years to see the levels of decrease that were experienced several decades ago. I do think that if we are experiencing COVID, you know, as an endemic disease, you know, 2-3 years down the line, I would expect, as you suggested, that we would become accustomed to this. This would become something that we would just live with. It would get added on to the additional toll of influenza that we expect every year. And this sort of ability to become numb to the costs, you know, the costs of preventable death is, I think this is a huge problem for the public health community. This should be unacceptable to us. And we need to make stronger arguments to our governments about the need to invest in this, not only because the people, you know, I think we need to make the arguments that our entire communities are less safe because of our lack of action.
Thank you. Thank you very much.